kunnen gaan zitten. Please take your seats. Welcome everybody, especially the candidate and his paranyms and his family in the room, but also the people online following this session. My name is Scholten. I'm emeritus professor at this university. I would like to emphasize that people who are not familiar with these types of sessions, it's not an exam. It's what we call a learned debate, a scientific discussion about the content of the thesis. There's a forced thesis. And here are all people, experts on this field, and they would like to discuss with the candidate. So I kindly ask whether the paranyms are ready. Yeah. Is the candidate ready?
Ready.
I hereby open this session. Mr. Doctoral Candidate, the board of the conferral of doctoral degrees of Utrecht University now grants you the opportunity to defend your thesis in public. And the first opponent is Professor De Wit. Professor De Wit is professor of primary care at this university, and he was also the chair of the assessment committee. Professor De Wit.
Thank you very much, Mr. Chairman. Dear candidate, first of all, I want to congratulate you on this manuscript and, of course, involve your supervisors in these compliments. It's an extensive work on the development of trauma systems in what you call emerging nations. And I think your studies contributed to the quality of trauma systems all over the world. And I want to emphasize the importance of the international comparison. And I realize all the effort that it took to collect all these data in these 17 or 18 chapters that you wrote. However, we are here to critically review your work and not only compliment. So I want to take you to chapter 17, in which you describe the results of the Saudi trauma registry in the King Saud Medical Center, and you compare them with another center, large trauma center in Australia. And in table 2 on page 292, you describe the demographics and the trauma background of the populations in these two centers. But of course, the quality of care is also determined by the available resources and the whole the way the centers are staffed and the expertise of the staff. So I wonder, how do you compare these two centers on that?
Hoglia, the opponent. It was actually King Saud Medical City, one of the largest hospital in the kingdom, especially in the whole Middle East region. And we know Saudi Arabia has huge burden of trauma. So now, 2015, we had an agreement with Alfred Hospital, who came across to Saudi Arabia to help us with the development of trauma system. And I also came from South Africa, and gradually we started the department and the center. So it was one of the initiatives which we took to make first the trauma registry, because if you do not have data, you cannot argue. So we started the trauma registry in 2017. And then this was the first year trauma registry data which we compared with the Australian Alfred, which is established already for years, the data, how to benchmark our quality of work. So it was actually risk-adjusted comparison. Mm-hmm. They made the adjustment of the age and of everything adjusted to compare both hospitals.
So you more or less controlled for the population that were in your studies, but how do you control for the skills available, for instance?
Yeah, that's one of the what you call it, limitation of the study. You cannot, because one is newly developed, another one is completely established trauma center.
Yeah, and how would you then foresee a kind of international comparison of quality of trauma centers? How do you, because you have to of course, control for all these factors then in order to
Yes,
have...
that's it will come with a gradual, when it become matured, automatically our skill will be improvement, and because that's what I do actually describe the whole. If you look at my whole things, once you have a matured system, automatically your patient management will be improved. So once it is matured, then you can have a comparable, you can compare. And moreover, we are going through accreditation process, level 1 trauma center process. So we have 218 criteria according to the Royal Australian College of Surgeons. Okay. So if we follow those things and if we fulfill that criteria, obviously you will be in certain level, and then you can compare.
Okay. Well, I'm sure the following opponents will come back to this as well. I have another question. I'm still within my time, Mr. Chairman. And that reflects on your experiences now, because you have compared these two systems in different countries. And you have learned a lot of lessons, I think. What would you advise the Ministry of Health of what I would call a developing country in Africa or in Asia who want to set up a high-quality trauma system? What would be your advice on the best way forward? Would it be to focus on high-quality central care, or would you very much
I would
prefer...
advise on three things. First of all, I would like to have a national trauma registry, because it's now only regional or in our hospital, which I should expand all over the country gradually. Number one. Number two, I would emphasize on research and development, because if you do not do research and development, you cannot argue, you cannot improve. Yeah. Number three, I would, quality assurance program. Mm-hmm. These three I will emphasize. This is the message to the country.
But would you focus on central availability of high quality resources, or would you say no, it needs to be peripherally?
No, I would like to have peripheral as well. And actually it is going through. The whole country, there is a transformation process is ongoing. By 2030, there is a pure plan in place. Okay. How we can go even from the center to the periphery.
To the periphery.
Yes.
Well, thank you very much for your answers, and I give the word back to the chairman.
Thank you. The discussion will be continued by Professor Schipper. Professor Schipper is Professor of Trauma Surgery at Leiden University. I would like to thank you on behalf of the Utrecht University for your willingness to participate in this discussion and for your willingness to join this session from Pretoria, South Africa. The floor is yours.
Thank you very much. Dear candidate, I would very much like to congratulate you on this impressive thesis. It took me quite some time to get through it, and I would also like to congratulate you on what you have done until now, because you also have a very impressive CV. And I wonder actually, but I'm not going to make a question of it, where you found the time to do all of this research and to write all of these papers. But that question we'll save for later, because I have obviously quite some other questions about chapters. And I would like to take you to chapter 14, a chapter in which you look at the incidence and nature of lower limb deep vein thrombosis. And to do so, you studied all polytrauma patients in the King Saud Medical Center from March to August in 2020 to determine the incidence of a nature of lower limb DVT polytrauma. Now, I wonder, in the same chapter, you write that the trauma unit admits 50 to 70 polytrauma patients per month. And this study ran 5 months, so that must have been 350 polytrauma patients, between 250 to 350. And you only included 169 for your study. How come?
Hoguler, the opponent, thank you very much for your question. Yes, we have admitted 350, even more, but the inclusion was only 169 because if you look, it had an intervention, which is ultrasound. And for every ultrasound, you have to pay. In our community, we have mixed type of eligibility, means Saudi population and non-Saudi population. Non-Saudi population, normally they have to pay from their pocket, means either the insurance company or himself has to pay. So to do this research, I did not want to burden those kind of population. So somebody did not give the consent, family, to expend some more money. So we excluded those kind of patients. So that's why the patient number came down to 169.
Okay, well, you brought me to my second question, actually, because that's about the exclusion criteria. I noted that you excluded the patients that could not pay for the ultrasound, but the ultrasounds, actually the research investigation, and in the Netherlands you might have noticed that it's not common that people pay for something that we do as academical research. So I wondered if you had thought about this, and I appreciate that it's common in Saudi Arabia, but this might also introduce a bias. Do you have any idea what way it might introduce a bias?
No, because the whole research was not funded, first of all. So even if I want to do, I have to take the consent from the patient, or I have to pay from my pocket.
Yes, but if from a scientific point of view, if you only take the people that may not be able to, that may be able to pay for the ultrasound, you have a selective population. For instance, the more well-to-do people that will take better care of their health and will take better care of their fractures or whatever. So that's a bias.
Yes,
that you're
a selection bias. Yes, I agree with you.
Yes.
But although, the Saudi people, they did not need to do this. This happened only for non-Saudi people. So there is selection bias. Yes, I agree with you.
Okay. So you also agree that probably should have been in your limitations then, I guess. And I was also wondering, did you also include people that used prophylaxis prior to the trauma? Because you write none did, but I can hardly imagine that you included 170 people that did not have any prophylaxis for VTA before the accident.
No. Actually, this whole group was on VTE prophylaxis. That's why we wanted to see, because what is the background of the study? Background of the study was to see we are doing, because we have to comply with the VTE prophylaxis risk assessment, and we have to put them on VTE prophylaxis. But in my clinical practice, I am seeing, although we are giving the VTE prophylaxis, patients are developing VTE. I wanted to see that incidence. That's why actually all of them are on VTE prophylaxis depending on the risk score, which I know.
We're misunderstanding each other, I think. I mean, prior to the accident, prior to the trauma.
Oh,
they
yes.
were not on.
No, none of them. Prior to the accident, none of them.
That's very interesting. Is there room for one more question, or have I used my time?
No, you are still on the
And I want to add one thing. The prior to the accident, because most of our population is young population, so usually they don't take the medication.
Yeah. Okay.
Yes.
About thrombosis prophylaxis. Have you studied that a bit more in depth? Because there's a lot of going on about the direct oral anticoagulants, the DOACs. Apixaban is one of them.
Yes.
And I noticed that you said in your study that they were set on oral medication, apixaban, as soon as they could take oral medication for prophylaxis.
Yes, we converted to oral.
Did you find any substantiation for prevention of thromboprophylaxis in polytrauma patients with apixaban? Because I looked and I couldn't find any.
No, this is our a hospital, because once patient can eat, it's a new anticoagulant, it's available in our pharmacy, we just convert it to the new. But I did not have it. This could be the next research. Yes.
Because right now it's only CME marked for hip fracture or hip joint replacement still. And I know it's coming up, but it's not, for this indication, it's not noted yet.
Yes, it's a local protocol, our.
Okay, thank you very much. I would like to return the word.
Thank you, Professor Schipper. The next opponent is Professor Kalkman. He is Professor of Anesthesiology at this university. The floor is yours.
Thank you, Mr. Rector. Dear candidate, first of all, my congratulations. This is really important work. It's also unique. Your journey as a surgeon has taken you from Bangladesh to Saudi Arabia and to South Africa, and now also intense contact with our country, the Netherlands. So your perspectives are really interesting. one of the things that really struck me at page 29 in your introduction of chapter 2 is a sea of apathy regarding trauma. I think that struck me. And so my first question is, there seems to be an apparent contradiction between the very high gross GDP of Saudi Arabia, it's a very rich oil country, and the difficulties of setting up a trauma center. And it actually seems that you were instrumental in getting a plan for the next 10 years. So why is this so hard in a country that is not poor?
The opponent, yes, actually that sentence I used for South Africa, honestly speaking. But it's all about, we are the first few trauma surgeons started to work there. Before it was a conventional way, general surgeon used to do that. Although they had understanding, but unfortunately I did not know actually why last 40 years did not happen in Saudi Arabia. But now actually due to the national health transformation and Vision 2030, it is quite rapidly growing. Even if you just compare last 5 years, the place we are now, I think we are quite advanced. We have even generated more than 20 trauma and acute care surgeons in the country in the last 5 years. So even in the leadership level, it is rapid transformation is happening.
Okay, that's really good to hear. In chapter 5, you write, after setting up the trauma care pathway, we're still talking about Saudi Arabia, you write it was a great challenge to implement it cluster-wise and regionally. But you don't give any details. Can you tell us a little more of the specific challenges you encountered?
The challenge is different mindset. Even, to make them understand, it's not easy. Even though I'm talking about the leadership level. In fact, if I give my situation, in my hospital, our chief executive officer background is even not surgery. Our chief medical officer is not even a surgeon. Even our associate executive director is an endocrinologist. So if you do not have a surgical background and if you don't accept trauma is a disease and it's a surgical disease and trauma is a huge burden. If you look at our history, Saudi Arabia is the leading cause of death in young population.
Oh, it's absolutely horrendous.
So to make them understand and to put the resources, to put everything, it was a great challenge. Many meetings, many things, very slow. To have these things implement, it was a challenge. Although it is going on, it is rolling on.
Well, that leads me to my next question, and it seems that both in South Africa, with a predominantly penetrating trauma, gunshots, stab wounds, horrible stuff, and Saudi Arabia, with this tenfold increase in road traffic accidents, that the pillar number 4, prevention, should be addressed as well. What is your role as a trauma center in achieving better prevention?
Yes, prevention is important, integral part of even trauma systems. So, although because as we are a surgeon, we may not have a direct impact on the prevention part. Even though, to have that as a level 1 trauma center, we have a collaboration with different authority, like Saudi Red Crescent Authority, Saudi Health Council, and so Vision Realization Office. So we are actually talking on, because to have the level 1 trauma center, that part we have to address. In fact, I myself with Prof. Linen doing one research on vision, means impact on vision and road traffic accident. But that did not came out. It's only 84 patients we recruited. That will also address the part of prevention part.
Okay. Mr. Rector, do I have time for a small... Yeah, so I was in chapter 6 about the tranexamic acid. I hate trials where the drug works when you give it early and it works negatively if you give it late. Steroid trials. So they have this magical 3 hours. Don't trust that anyway. But having said that, in South Africa you never get there. It's median time 10 hours. I mean, so why can't we give it in the field?
Why can't be?
Yeah. Why can't we give that
This
on the
only
scene?
worry is the because we have some incident with VTE, especially PE. If it happens pre-hospital, although it's a very rare occasion, even I think 1 or 2
I know.
Yes.
I know that's rare. So
Rare.
it's just you have to compare.
And not only that,
two risks.
if you look at the expertise at the pre-hospital level, even in South Africa and Saudi Arabia, they have like paramedics. Not all ambulance people are paramedics or are allowed to give any introduction of the medication. So it needs political things. It
I
needs
saw that,
experience,
and that's why I wonder.
So that's why actually this research actually is to advocate, to administer, especially in the lower and middle income country, because our pre-hospital time is longer. If I have to get benefit of this trial, maybe we will be benefited if we bleeding patient if we address these things at the scene or immediately after the incident.
Maybe with remote supervision. Okay, thank you so much for your answers. Very interesting work. Congratulations.
Thank you, Professor Kootman. I have a question for your daughter. How's your father doing? He's doing well, isn't he? It's a bit boring or not? You can count the paintings and then tell me afterwards how many there are. Okay? Okay. The next opponent is Dr. Ferré. He is surgeon at the UMC Utrecht. The floor is yours. Oh, sorry. Kijk naar de verkeerde. Yes.
Dear candidate, congratulations on a wonderful thesis. Also to the promotional team, Professor Lene and Dr. Van Baal. I want to start our discussion also in chapter 17. And what really struck me was the difference in mortality between the Alfred Hospital in Australia and the King Saudi Medical Center, the 4-fold increased mortality rate despite correction for age and ISS and other stuff. And you touched on this already a bit with the previous opponent, that there are some struggles in the system to overcome. And what would you say are the lead factors that lead to this increased mortality besides awareness and change in the system? What would you change if you could?
Yeah, Jekala, the opponent. Yes, I agree with you, these things. The problem actually, our system is not developed. So in my practical life, we feel a lot of patients, fixed dilated people. No, means it's a futile case. They transfer from the peripheral hospital to our hospital. So those patients shouldn't be transferred. Every month we do the mortality meeting. Out of, from my department, 4 or 5 mortality, 3 will be like this patient. 3 to 4 means those patients already dead in the emergency department, especially with severe head trauma. So what happens, they even when they transfer the patient, sometimes they lie. How they lie? They say GCS4. They say pupils is still reactive. But when I received the patient, I found it's a futile head trauma. Those patients are counting on our registry, but they have a matured system, so they don't accept those patients. So that's why the difference. I don't think it's a quality of care inside the hospital. I think we are not inferior in any way if you compare it Alfred. Even I have been there. I worked there.
So you would say that the odds ratios for preventable death, there would be no difference?
Yes, I agree. Yes.
Okay, but that brings me to another interesting point, because in the same chapter you say that the median time to craniotomy and procedures is 10 hours, which means that 50% of craniotomy procedures are performed less or more than 10 hours after a diagnosis. I would say that that's rather late.
Yes, yes, it's difficult to say, because our neurosurgical. This is quite neurosurgical decision. That's what our observation. But I don't think if patient needs craniotomy to waits for 10 hours. It's not a practical. It happens within 1 hour. Actually, this is my. But that's actually from the result from the registry. Even I also want to mention the limitation of the registry also. For the registry, we have newly trained people, registry people. This is under my department, like a registry department. They have data collectors, and our system, the timing It's not like well validated yet. It's still paper based. We don't know exactly when patient coming. Many things are defect, but it is changing because of the electronic. We are moving to complete digitalization. Completely, it will be from the injury up to the whole thing will be the computerized. I think after that it will improve all these numbers.
Yeah.
Yeah.
So you would say that there's also a
Yes.
registry issue.
A registry issue.
Yeah. You said earlier that there's a challenge to get people's mindsets onto trauma, and is the trauma surgeon the one who has the oversight over these patients? Say a patient comes in with multiple injuries, but also has an epidural hematoma. Who is the doctor that makes sure that the patient doesn't have to wait 10 hours to get the surgery? Is that the nurse surgeon or is the trauma surgeon?
Now trauma surgeon. We have a completely dedicated trauma. My department, once patient on the basis of criteria, TTA, trauma team activation or consult. 2 tier we do, trauma team activation or trauma team consultation. If it is activation, our team mobilize immediately. It's on site and it's all supervised by the trauma surgeon now. But if it's isolated trauma, then we don't take those patients. Those patient goes to neurosurgical department or orthopedic department or whatever, spinal department like this. So currently the major trauma is oversighted by us.
Yeah, that's clear. Can I continue? Yes. Yeah. So that brings me to something about chapter 8. And in this chapter you examine complication in patients who have an SI of above 1 and below 1, a shock index. So a shock index of 1 and higher, that they deemed more blood products, more ICU admission. But I saw in table 1 that the trauma team activation is only 19%.
Yeah, that's also the issue of the, trauma registry. Is that
a registry issue?
Yes. This data from the registry data, 6,669 patients, which is the 3rd largest in the world. Although the trauma team activation less because it's under triage. So that issue with the documentation and registry, who is collecting the data, but I cannot change those because I have to go to the file and check again. Yeah. So we see practically actually in our hospital more TTA, but it's not documented.
Yeah. So we can rest assured that
yes,
it's 100% when the SI is 1 or higher.
No, that's good because that is the vitals. That is systolic blood pressure and heart rate.
Yeah. Okay. One question? Yeah, I'll just continue until you tell me to stop. Right? In chapter 7, it was a chapter about nurse training improvement, and obviously when you train motivated, skilled professionals, they improve. That was not something that came as a shock to me. But what I missed in that chapter was, but maybe you can elaborate on that, is how you would apply the extra knowledge in a practical setting. Because this knowledge is just an exam, but that trauma team activation and stuff that you do as a trauma surgeon with your team is teamwork, and that's...
Yes, we have a regular drill, and then there's trauma patients coming all over, so means regular business. So although the training system is based on the knowledge, but at the same time, if you look at the 3 case scenario, they have to do hands-on return. So it's not just, although that is not examined, but when you do the hands-on return, the instructor is seeing what she's doing or what he's doing. So that's also sort of evolution.
And is that something that you do with the whole team?
Yes,
the entire team?
It's
so that's in anesthesiologist.
Yes, it's a full trauma team formation. You do the same. Yes.
So it's an anesthesiologist, a trauma surgeon.
Although in our core trauma team, anesthesiologist is not there because our emergency department, they take care of the airway problem. So only the difficult airway, anesthesiologists are involved in our setting. But if it is a surgical airway, trauma surgeon involves. So our trauma team actually is not in the primary trauma team. Anesthesiologist is not included because we have already 3 trauma surgeon plus emergency physician, 2-3 people from there.
Okay, last question, if I may. Yeah,
short one.
It can be quite short, I think. In chapter 5, the difference between patients with complications and without complications is there's a 30-minute delay until they reach the hospital. And so
This
50,
is
50
on the
minutes.
emergency medicine, that one. Which one is this one?
Chapter 5,
Yes.
there was the patient with complications had a 50-minute delay from the scene to the hospital. And what would your suggestion be for improving that very prolonged pre-hospital time?
Yeah, I emphasized on emergency medical response. That part actually, because patient has injury, patient's lying down in the scene, they are not coming on time, and that time patient is bleeding maybe, right? I was emphasizing on that part. So we have to improve the resources, of course, because if we have enough ambulance, enough pre-hospital personnel, why they are not coming early? This is the only reason, because they cannot cover whole population very quickly. So we have to emphasize on the resources, especially the ambulance center, more personnel, more trained personnel, those things. So automatically it will improve. And we have now resource command center, they are looking at these things.
So is it delay in response, or is it that they stay too
Delay
long on
in
the scene?
response, the first part.
Yeah.
Delay in response.
Okay.
Thank you very much. The discussion will be continued by Professor Euner. He is Professor of Orthopedic Surgery, in particular the spinal surgery at this university. Professor
Thank you,
Euner.
Mr. Director. Dear candidate, I would like to also congratulate you with this broad and work of about many trauma issues in 2 different settings where you get a lot of experience, and I'm glad that you're also giving us the opportunity to see that. I'm very impressed by the spectrum of many different studies. I have a couple of questions, because you're now an expert, international expert. I want to hear about a couple of things about your. First of all, I'm a spine surgeon, so I'm I read the chapter 12 with extra interest about the vertebral artery injuries. So I want to ask you a couple of questions on that. You say that there's a retrospective study of 1,084 patients. All of these get a trauma CT scans, okay? And do they get an IV contrast during that trauma CT or not?
Yes, IV contrasted CT.
Okay, so you're able to image the vertebral arteries in all of them?
No, the neck is without contrast.
Excuse me?
Neck is without contrast.
Okay, so
when they use the contrast, but when they take head and neck, they don't use the contrast for pan CT, first CT. So once we have the CT scan available, then we go through this. There is any Denver criteria, modified Denver criteria follow. Yes. If there is one is with the Denver criteria, then second CT will be the CT neck angio.
Okay, so this CT angio, so you don't give them an IV and contrast in all these patients. Yes. You're not imaging the vertebral artery in all of these cases.
No, not 1,000. No, it's selected patients.
Okay.
Depending on the criteria.
Okay, then you have done it. You have done that in 120 of these patients. 11% of them there were Denver criteria, and you said, okay, we're going to do an angiogram. And there were 84 patients with C-spine fractures, and 10 of them had vertebral artery injuries. How many patients were there without cervical spine injuries and vertebral artery injury?
How many of them?
How many of the
without C-spine
C-spine fracture?
I think just only one. It was a condyle fracture.
The condyle fracture is also C-spine fracture.
So then all of them were
part of the C-spine.
Yes.
So there was none. How do you get done at the end and say that no univariable association of vertebral artery injury with C-spine fracture is found?
This is maybe due to the low number. It means our sample size is very low, but the analysis did not show.
But that doesn't make sense, does it? So that means that is a statistical fallacy. I was saying,
because the condyle, some people, they don't think it's a part of the base of a skull instead of cervical spine.
Even if you take out the condyle fracture case, it would not make sense to say that there is no association with cervical spine injury, because all of the vertebral artery injuries are involved, or at least 9 out of 10 of them are involved with the C-spine fracture. How do you get statistically that univariate analysis? That's what I mean with the statistical fallacy. If you get this kind of reactions, the results, you should ask, does it make sense what the statistics say?
Yes, but the statistics part was done by the Alfred, this one. And the Professor Arul Arners is a very quite famous biostatistician, so I cannot say anything, whatever his findings. And it was actually reviewer question, and we answered this question with one paragraph, I think, there.
So that needs, it is good that if you're doing big data and a lot of studies, but we have to think about that. Okay, what does that statistical result coming from the computer say to us? Does it make sense? And if it doesn't make sense, we should go back to the studies and say, okay, just explain to me, what does it mean? How is it possible that only the patient with C-spine fractures have vertebral artery injury, and with the statistical analysis, we do not find any association?
Yes, I agree with you.
Okay, but my main question is, you're now an international expert on this area. I would like to ask you, then, why is there so lack of interest in the global medical community, but also in the global media community, about that, what you call epidemics of trauma in the developing and emerging nations? Because that is number one in mortality and morbidity in many of these countries. But I've never seen an editorial in the Lancet or the BMG or the JAMA about the epidemics of trauma. Why is that?
I did not get your question.
You were able to, in Saudi Arabia, yes, you were able to convince the people who have power that the trauma is a major concern. So that's very good that in Vision 2030 you have put that. But in the worldwide, we don't have that.
Yes,
we don't have that.
We are working on it.
We still that when you talk about the emerging and the developing nations,
yes,
they're still thinking about infectious diseases. That's a major thing. And even there's now a growing concern that the first world degenerative disorders like obesity and diabetes and cancer is becoming. But there's no talk about an epidemics of trauma.
Yeah.
I've never seen an editorial over epidemics of trauma.
Yes,
why is that, and how can we change that?
It's the people. Like, we are the first few people who understand, who are working for it, and it is gradually coming up. You will see in future.
Okay, maybe
and even this thesis, our World Health Organization are interested. So it is coming up. You will see in the big paper and big things in the international journals like Lancet or others.
Very good. So what you have done in Saudi Arabia, maybe you should just expand it to the whole world. I think that we need it, because even WHO, there is no section who is interested in the epidemics of trauma. Okay, they have published a couple of reports, yes, over the road safety and things like that. But I think that it is time that, and you might be one of the leaders of that.
Yes, I agree.
Okay, thank you very much. I would like to give it word back to you.
Thank you, Professor Euner. The discussion will be continued by Dr. Hietbrink. He is a surgeon and also the head of the traumatology department of the UMC Utrecht. The floor is yours.
Dear candidate, also my compliments for your immense work, and also compliments to your promotion team. I think you're to be complimented to put trauma as a disease. You stated several times. You mentioned the burden of trauma on a nation and the burden on the system. And I think this kind of research, I really like it. I mean, this is where research, management, and politics come together. And yeah, I think you made a huge step forward for Saudi Arabia and perhaps, as Professor Euner said, for the world. In your major focus is on trauma system development, and you gave a short frame for it in your own terms. What is a trauma system? Can you rephrase?
Singularity opponent. Trauma system is a complete care in a defined geographic area for the acutely injured patient from the injury to the rehabilitation. So whole spectrum called trauma system.
And in your mind, what are the key factors or the key elements in such a system?
The key elements is pre-hospital element, in-hospital and rehabilitation. So in hospital you can divide into different, like in the emergency department in the hospital, in the definitive management.
Yeah, so you have several building blocks.
Yes, so pre-hospital, in-hospital emergency department,
Yeah.
definitive management, rehabilitation.
And at the end of the chain, what is your most important outcome parameter?
Outcome is to send the patient to his home. This is the most important outcome. If you cannot, some patient will die, some patient will go to for long-term or short-term rehabilitation.
Yeah, so that's the desirable outcome, sending someone home.
Of course, I want every single trauma patient should go home.
But
That is my wish.
maybe I should rephrase. What is your main outcome component, what you can measure, what you would like to measure?
Yes, mortality is one of the main outcome component. Then disability is one of the main outcome component you can measure.
Okay, and then because there were already some questions on increased mortality between the different hospitals you visited or learned from, but you also saw differences. You said it's crude mortality is perhaps not the way to go. So to make it a little bit more sharp, what kind of mortality would you like to measure?
Depending on on injury severity score, because crude mortality is just how many patients you admitted, how many patients died.
Yeah.
But then you can categorize it by the injury severity score. So then you can have better what's supposed to die, what's not supposed, or even TRIS score. Different scores available. Trauma injury severity score, TRIS score. You can predict the mortality.
Yeah, so you want a corrected mortality for people you might have saved,
yes,
right?
Yes.
So
adjusted mortality, you can say.
Yeah, you want to measure preventable deaths.
Yes.
So did you, as part of the trauma system, I think an essential part is the morbidity and mortality meeting.
Yes.
And you touched on it several times, at least you mentioned it, but can you explain did you organize it?
Yes, we have a monthly mortality meeting. Normally, we have also quality management and patient safety department. So normally all mortality, irrespective, whole hospital goes to them. Then they segregate the trauma part and they send to us, send to me, my department. Then I check how many deaths are there, right? And then I give it for review. We have a committee. We give to them to go through the file and make a format a mortality. There is a structured way to do it. And then at the end, every Wednesday, last Wednesday of the month, we have a meeting, or a formal meeting. So it's at the department level. So after a departmental meeting was maybe out of 5 cases, 1 cases maybe need to be escalated. Means we have departmental meeting, subsequently we have general hospital mortality and morbidity surgical subcommittee meeting, and I'm also chairing that meeting. And then there is another one, the hospital-wide meeting, and then means cluster-wide meeting. So it escalates slowly. Not every case, maybe 1 case is controversial case or something can be improved. So those cases we refer to higher. So it's a very organized mortality meeting in our hospital.
Yeah, because also from your thesis and you as a person, I think you're a very curious person, right? And adventurous. You like to travel the world and see other stuff. And this also reflects on your thesis a little bit, because the data you gathered, I think you gathered.
Yes.
Yeah, you did it.
Yes.
Yeah. So my question would be, if you would go to, say, London to work, would the system in Saudi Arabia still be intact?
Again, please.
Would the system in Saudi Arabia, in Kingdom Hospital,
yes,
would it still stay the same, or would it disappear as you leave?
No, it is an organized system. It will stay.
And how did? Yeah.
Because it's getting matured now. Even if I leave, it will stay.
And how did you anchor this system?
Because it's a closed loop, because hospital has the now, as I said, quality management team. So it's not like me. Now I have already, the structured people to do, and then management has. So even if I leave, it will stay.
Yeah. So you have management support, you have government support.
Yeah, government support,
yeah.
Yes. And every single, the death, especially if it's a major death, you have to report to the ministry. Especially sentinel event. So it's a closed loop.
The Ministry of Health is checking your fatalities.
Yes, outcome.
That's an interesting one.
Yes, they do. Even some deaths you have to report within 24 hours, and then that night you cannot even sleep.
Okay. And this is also part of your 2030 Kingdom Vision program.
Yeah.
These elements.
Yes.
Yeah. And do you see any room or opportunity to expand the 2030 vision of the Kingdom of Saudi Arabia to a more worldwide setting? Because I think this is really, yeah.
Yes, of course. In fact, even many African countries personally emailing me.
Yeah.
They want to. Even Ethiopia, I received an email. They want trauma system implementation in their country. So of course, this will like a foundation for many developing countries.
And for Western countries?
Yeah, why not? There is always room for improvement. So it depends.
Because I think many Western countries
Yes.
do have a trauma system, but it's more or less embedded. This is actually a vision for several years. And
Yes.
also in Europe, a lot of countries are missing that. But okay. And if you have to, because if you want to expand this program with your trauma system and your people in it to inequality control to, for say, South Africa, Mozambique, what essential elements would you transfer from your high-income country to your low-income country and the other way around?
Yes, so I would like to do the implementation of this thing with, the budget is the main issue for the low income, but even though you can change things, you can, without limited budget, you implement the process to have the better outcome of the patient.
Thank you, Dr. Hietbrink. The committee will now withdraw for further deliberation and the session is adjourned. Please take your seats. I hereby reopen the session. Mr. Doctoral Candidate, this committee, installed by the Board of the Conferral of Doctoral Degrees, has considered your dissertation and has heard your defense. The committee has decided to confer on you the title of Doctor. I now kindly ask the Supervisor, Professor Lehnen, to invest you with the honors in the traditional fashion.
By virtue of the authority conferred on us by law and according to the decision of the Board of Conferral of Doctoral Degrees present at this session, I hereby confer upon you, Sharfuddin Chowdhury, the doctoral degree to which are attached all rights and obligations towards science and society as laid down by law and custom. Do you promise always to perform your duties according to the principles of academic integrity, honestly and scrupulously, critically and transparently, and independently and impartially?
Yes, I promise.
Then I present you with a diploma signed by the rector and supervisor and co-supervisor and bearing the Great Seal of the University of Utrecht. Congratulations. Thank you. Great job. Okay. It's on the phone?
It is a video.
Very good. Dear Dr. Chowdhury, MD, Ph.D., my sincere congratulations with your new achievement as a PhD. And also, please accept my admiration for the huge work you have done over the last years and the relentless tempo you accomplished this. It started some years ago, even before we met. I was asked to evaluate and advise about trauma and acute care as well as intensive care in the King Saud Medical City in Riyadh in Saudi Arabia. What I found was patches of systems that were drawn from all over the world. Parts from a trauma system were drawn from Australia. The 150-bed ICU was organized around French-educated anesthetists. General surgery, including trauma, was more or less organized around more English-educated general surgeons with virtually no interest in trauma. Thoracic surgeons only doing lung and esophageal cancer surgery, and the emergency department, ran by emergency physicians, ran in Australia and the UK with no overall concept, however, treating 150,000 patients a year in the ER. That there was a need for better trauma care was evident from what I saw at that hospital at that time. Patients with unstable cervical fractures waiting for weeks and even months for a spine operation, fracture surgery only when the elective orthopedic surgery was postponed, no home for the multiply injured patients, patchy care and no real system. The chief of surgery saw really the problem, but had no support in solving it. After my report, a few years later, I was again asked to have a look and again report it. You had been hired and had a little staff of not very well trauma-trained Greek doctors, and at least a small trauma ward was founded. Nurses were trained, rehabilitation was organized, orthopedic surgeons were lined up, good for you. ICU was still a problem because the surgeons had virtually no say, and also the outlines of a system approach could be discerned. Originating from Bangladesh, you went to South Africa for your surgical training. During your training in Grote Schuur with Andy Nicol, you had seen all the big problems and challenges in trauma, clinically, but also organizational-wise. Your interest in quality of care led to the first steps in scientific evaluation of care provided, which was documented in this thesis. Moreover, it led to a large number of papers in all different aspects of trauma care. The major steps ahead in reorganization in the care in King Saud were also documented and evaluated. On top of that, you made good use of the major plans that were initiated by the Saudi Crown Prince in his major effort called 2030 to reorganize the country, coming from only oil-dependent to a completely non-oil-dependent country, with a large paragraph on reorganization of healthcare as you described in your thesis. In contrast to many other countries, trauma, as alluded to already by Professor Euner, is one of the leading causes of death in hospital admissions in Saudi Arabia, and is therefore a very prominent in the 2030 plans. That trauma is so prominent is explained as 70% of those patients after motor vehicle accidents I saw in that week at King Saud did not have a driver's license. But of course, if you can ride a camel, you also can drive a car. Dear Sharaf, I admire you very much for your drive and persistence, both in your daily care but also in your scientific endeavors. For me, this journey was a highlight. Your reaction time for me was unprecedented. Your texts were a pleasure to read and a relief compared to most Dutch PhD students. Dr. Verlee. You are a fast learner and also very flexible, both entities that make you survive in a very difficult environment in Saudi Arabia. Sharaf, the work is done. Please enjoy your stay in Europe, and after that, please continue your work and scientific endeavors. I wish you and your family all the best for the future, and I'll give back the word to the Director.
Zeer geleerde heer, very learned sir. On behalf of the Board of the Conferral of Doctoral Degrees, I congratulate you on the honors which have been bestowed on you. You have written a very thick book, and you talk very quickly, so in principle you have had 2 defenses. It was in one time, because you have spent more words than most candidates do. So you have twice a doctoral degree now, maybe. I congratulate you, of course. I congratulate your wife and your daughter. I will ask your daughter afterwards how many pictures there are in this room, so I'm very curious to know that, but I will do that afterwards. I wish you all the best for the future, and I hereby conclude this session. I would like to give Professor Schipper the opportunity to say some words to you.
Thank you. I would like to very much congratulate you on this magnificent effort, on what you did today, on the discussion that we've had. You're obviously very enthusiastic and very driven to bring the whole care in trauma, national and international, to a higher plane. And I congratulate you on that. I hope you will find time and energy to continue with the good work you're doing. And then we probably meet again somewhere, somehow. Have a nice day and enjoy what you've done today.
Thank you very much, Professor Schipper. Now the beadle will tell us what to do.